from the perspective of a GP, in order to require a consultation with a geriatrician, I would suggest that you don't actually have to be old. What you do need, however, is multiple pathologies, probably multiple medications, and multiple problems that need to be solved which aren't necessarily linked to hard, fast pathologies. So, for example, a patient might have a problem with walking outside. This can be because of an issue with confidence. It could be an issue with balance. The skill of the geriatrician is identifying things that can be changed in order to help somebody balance, help somebody walk more easily, within the context of multiple pathologies. As well as my role as a GP, I also work in our local Rehabilitation Day Hospital. The Rehabilitation Day Hospital is a multidisciplinary assessment and treatment unit for adults. Although we come under the umbrella of clinical gerontology, our remit is to treat any adult who requires multidisciplinary input. We have a well-established multidisciplinary team consisting of medics, nurses, occupational therapists, physiotherapists. We have access to a large district general hospital, so we have dietetics, podiatry and full support from medical diagnostics. A patient who comes in has a comprehensive geriatric assessment performed by the members of the team. They are assigned a named nurse, and after their first visit to us for investigation and assessment, they then go into rehabilitation. We usually see people for about 6 weeks, although we have people who will stay for longer or for shorter periods of time. We also run clinics for people who fall, clinics for people with cardiac failure, and our sister day hospital up at Rookwood also does continence clinic. We have a day a month where we see patients with Parkinson's disease exclusively, and so we have skills which are more specialist within the field of clinical gerontology. A patient comes to mind who I saw firstly in general practice, then I saw her in day hospital, and then subsequently I've done follow-up for her in general practice. And she presented with back pain as a result of a new vertebral fracture because she has osteoporosis. Her mobility was quite poor, she wasn't going out, and she was becoming increasingly socially isolated. So she came up to the day hospital for a multidisciplinary assessment. I spent time with her sorting out her medication. I spent time with her organising a change in her treatment for osteoporosis, and I sorted out her analgesic problems. She had physiotherapy, which helped with her confidence and her balance. She was provided with a walking aid to ensure that she felt safe when she was going out. And after 8 weeks of therapy, including relaxation therapies and functional activities in occupational therapy, we discharged her. I've seen her a number of times in primary care since, when I have taken time to reassess her analgesia further reassess her polypharmacy, and she was feeling so confident within 6 weeks of leaving the day hospital that she actually flew to see her family up in Scotland, and she is a lot less socially isolated as a result. Essentially, we see our role in day hospital helping to deal with little problems that people have to help them maintain their independence in daily living. We're not about taking things away from people, we're about enabling people to live independently and to manage their own illnesses. Another example of a 92-year-old lady who has just started in rehabilitation in the day hospital. She'd had an 8-week admission to hospital, during which she didn't particularly want to take part in rehabilitation. She was initially admitted to hospital after a fall. She suffered some fractured ribs, and a CT scan of her abdomen suggested that she might have a pancreatic malignancy. She was told that she had a pancreatic malignancy, and everybody was prepared for the fact that she was quite seriously ill. She stayed in hospital for the 8 weeks and in the end decided that she wanted to go home, so she signed her own discharge. The day before she was discharged, it was discovered that she didn't actually have pancreatic cancer at all. She has spent about 8 weeks at home with a 4 times daily care package for toileting, washing, dressing. She's unable to transfer from a chair to the commode or chair to bed unassisted, and she's really quite worried about her continence as a result. She came to see us in day hospital quite recently, and it is our intention with this lady to help improve her mobility, first of all by helping her to stand independently, get her confidence in her mobility back, to see whether she can actually live independently at home. She told me that when she was in hospital, her family were quite keen for her to consider going into a nursing home. Given that this particular lady doesn't have any issues with cognition, I could fully understand her desire to go home when she was in hospital, but what she has realised since being at home is that perhaps she needs slightly more input from caring services than she's currently able to get at home. Our intention is to help her rehabilitate. If she requires either residential care or nursing home care, when we have finished our rehabilitation, we will be able to counsel her and help her to choose an appropriate place to live.